Good evening, everybody. It's so good to be back with you. I'm excited. I look forward to I like to talk. And so when I'm talking about something that I know and I understand, I really get excited about it. So I'm very happy to be here with you. As she mentioned, for those who don't know, I am Dr. Monique May, a board certified family physician, over 20 years of clinical practice, have worked in a variety of settings from hospitals to my own practice to patients' homes, work sites, you name it, telemedicine. So seen a little bit of everything, I think, in that time. So today I am going to spend some time with you talking about why should we go to the doctor if you feel okay. So please be sure to jot down your questions. You can even put them in the chat. We'll do my best to get to all of them at the end because I do want to leave time for questions and answers at the end. So, um, okay, so we're going to go ahead and get started. So, why should you go to the doctor if you feel okay? Well, that is kind of a loaded question, and I think you kind of figure out from us being here that there's going to be several reasons why you should go. Number one, we'll talk about high blood pressure, and by show of hands or in the chat, who here has heard of the nickname or the other name for high blood pressure as the silent killer? If you've heard that before, go ahead and just type yes in the chat for me. Has anyone heard of that before, that hypertension or high blood pressure is a silent killer? Well, if you haven't, it is. It is called that because, okay, one person, good. Because you can have it and not know that you have it. And it can be doing damage in the background, damage to your brain, to your heart, to your kidneys. And so over time, that increases your risk for things like heart attacks and stroke, which can lead to an untimely death. So those of you who were at the first meeting that we had in person, you may have seen this chart. Hopefully you got a copy of it because I had laminated ones there. But this is the American Heart Association, American Stroke Association's table for what our goal is for blood pressure. And I will tell you, when I was diagnosed with high blood pressure back in 2002, 2003, I had zero symptoms. I was busy at work. I had seen about 18 patients that morning and had an insurance physical. You know how they come and ask you some questions, take a little bit of blood and urine. Well, I had arranged to have that done at my job. And so, busy morning in clinic, felt fine. And so when the nurse or the person doing my physical took my blood pressure, it was 160 over 100. I laughed. I was like, do that again. Surely that's not correct. But sure enough, on repeat, it was about the same. And so I followed up with my doctor, and sure enough, I had hypertension. We don't make the diagnosis of high blood pressure just on one reading. Typically, it's 2 weeks, at least in between. But as you can see here, a normal blood pressure is less than 120 on the top, or the systolic number, and less than 80 on the bottom, or diastolic. Systolic and diastolic just means the amount of pressure that that the blood vessels are under as the heart pumps and relaxes. So when the heart squeezes, you have the systolic, which is when the heart is under contraction, and then diastolic, when the heart muscle relax. So less than 120 over 80 is ideal. If you come in between 121 to 129 on the top, anything up to 80 on the bottom, that's considered elevated. And then stage 1 hypertension is anything over 130. So those numbers have actually gone down. We used to say it was 140. Now 130 is considered high blood pressure, early, but still high blood pressure. And then on the bottom, if it's 80 to 89, that's elevated. Stage 2 hypertension is if it's 140 over 90 on the top, top and bottom. And then stage 3, where we consider, where we consider a hypertensive crisis, is if it's higher than 180 and higher than 120 on the bottom. So hopefully you all have this chart. If not, let me know. I certainly can get some copies to Gwen for you. So we all know about high blood pressure, and it affects 30% of Americans, causes 60,000 deaths yearly. 20%, again, 20% of people who have it don't know they have it. And over 40% of African American men and women in this country have high blood pressure. And as I mentioned before, it affects the brain, eyes, heart, and kidneys. And the only way to know you have it is what? Someone checking your blood pressure. So one thing that when you walk in the door and the doctor checks your blood pressure or the staff checks your blood pressure, that's where we start to gather that information. Now, I will tell you, more often than not, because everyone is rushing around and we, pressed for time, blood pressures are not always measured as accurately as they should be in the doctor's office. So the next time you go to your doctor, I want you to pay attention and be sure you're sitting with your back supported, legs and feet uncrossed, and legs uncrossed and feet flat on the floor. Just crossing your legs at the ankle or at the knees can actually elevate or raise your blood pressure. Avoid from talking, chewing, shaking your leg, anything like that. You really want to sit calmly, quietly, back supported with your legs slightly bent and knees and feet on the floor. I realize that doesn't always happen, and you can even ask the assistant, hey, can I have a few minutes to kind of maybe just settle myself and then my blood pressure. So that's a reasonable request. And then of course, if you're monitoring your pressures at home, you should be able to do that as well. So the next big thing is cancer screenings. Now, as I mentioned, I'm a family practice doctor, so this is my, this is what I grew up on. This is what, as a baby family practice doctor, even in medical school residency, you learn that if we can prevent something, in other words, if we look for it before it finds you, your chances of doing better are higher. And so we don't want to wait until your cancer is causing a problem. We want to catch it when the cells are small and they haven't spread and grown to other parts of the body. So, and I have, personally, my mother, I will share this story. My mother was not the most, what we call compliant. She had not been following up with her doctor as far as mammograms, and she never had her colonoscopy at the age of 50 like we recommend, and she ends up at the age of 60 being diagnosed with advanced breast cancer and colon cancer. But thank God she is a survivor of both 10 years later, but that was due in large part to just not getting screenings done. And unfortunately, sometimes in African Americans, because of societal issues, either lack of access to healthcare, not enough coverage insurance-wise, or what have you, oftentimes, unfortunately, we present in later stages of disease where at that point we're trying to catch up, and the disease might be more advanced versus if we were able to get in earlier when again the tumor is small or there are just a few abnormal cells. So in this country, the most common cancer types, and this is as of 2020, is going to be breast, lung, prostate, colon, and skin or melanoma cancer. The asterisks, I wanted to just make a comment. Prostate cancer can be a different disease if you're a Black man versus a white man. Black men are more likely to have more aggressive disease, can have it younger, and can actually die from prostate cancer, whereas Caucasian men may die with prostate cancer. Well, what do I mean by that? Meaning they'll live long enough that they may die from heart disease or some other condition, and on autopsy, they see that, oh, by the way, they had prostate cancer, but it was not aggressive. They were not going to die from it. Whereas the opposite of that can be true in African American men. And so because of that, there's a lot of kind of controversy about when do we screen for it, how do we screen for it. But in general, Black men are recommended to start in their 40s, 45 or so, to start getting checked for prostate cancer with a PSA or the blood test. There's a rectal exam where the doctor checks to try to feel the size of the prostate. Whereas in white men, we may not start that recommendation till age 50, or if there's a family member, if there's a father or brother, first degree family member who is diagnosed, you'd want to start. And pretty much with any cancer, you want to start screening about 10 years younger than the person who was diagnosed. So for colon cancer, we typically start recommending that you get your first colonoscopy at age 50. But because my mother was diagnosed with colonoscopy, I had my first one at age 40. And I'll be having my next one next month because I turn 50 next week. So it's every 10 years. So, and then for melanoma, I just want to mention when we think of skin cancer, we don't tend to think of that as something Black people get because the risk, one of the big risk factors for skin cancer is sun worshiping, and so we don't typically lay out at the beach, although I admit I miss the beach. I miss laying out laying out on the beach. But generally speaking, we're not in the tanning beds. We're not spending hours and hours in the sun. And so our risk for skin cancer is lower, but that does not mean that we cannot get skin cancer. And particularly melanoma, which is the most aggressive form of skin cancer. And does anyone here know, there was a famous person, a famous Black person who actually died from melanoma. Does anybody know who that was? If anybody knows, and this wasn't recently, I'll give you, he was a musician. I'll narrow it down for you. Anybody can take a guess as to who I'm referring to? No takers? Bob Marley. Bob Marley actually died from complications from melanoma. And those who may not know, he was young. He wasn't even 40 years old. And it started in his toe. And he thought, being Jamaican, they play soccer. He thought that he just had a bruise from kicking the ball. And by the time they really realized what was going on, they had wanted to amputate, but because of his Rastafarian faith, he did not want to go for the aggressive amputation, which would be required with melanoma. With melanoma, once it's diagnosed, they really need to cut a large part to get rid of the cancer. He wasn't going for that until they treated it as best they could, but he unfortunately ended up succumbing to melanoma. And so in African Americans, when we do get melanoma, it does tend to be in the toes, the fingers, kind of at what we call the extremities. So in our nail beds, things like that. And so be mindful of that. Just because we have skin pigment does not mean that we cannot get skin cancer, because the melanin in our skin does tend to protect us from the skin cancer associated with sun worshiping, but we are not completely immune. Okay. And then the most common cancer deaths, the types of cancer that tend to cause most deaths in this country are going to be lung cancer, breast cancer, pancreatic cancer, and breast. Oh, I'm sorry, I have breast on here twice. That should be colon. The last one is colon cancer. So next, roll up those sleeves. Vaccines are not just for babies. So vaccines actually help your body to fight infection by exposing you to the disease that we're trying to prevent. And the one thing that comes to mind is flu shots. I can't tell you how many people, and probably some of you here today, believe that the flu vaccine causes the flu. Not true. But what possibly happens is that when you get a vaccine, any vaccine, flu vaccine, tetanus, any of them out there, our immune system is kind of triggered because we want that. We want the body to start rev up and start recognizing, oh, wait, there's a foreign invader. We need to isolate and protect. But that process in and of itself doesn't cause the flu, but it can give you kind of achiness, a low-grade fever. If you have been exposed to the flu before you got the vaccine, because the vaccine doesn't work immediately, but say in the 2 to 3 weeks before you got the vaccine, you were exposed to the flu, then yeah, you're still going to get the flu. And then the other issue is that it could be something else. The influenza vaccine only protects you against influenza A and B. But there are lots of other viruses out there, and so it's not going to protect you against those. So just wanted to say that because there's a lot of kind of myths and misconceptions about, oh, if I got this flu shot, it gave me the flu, and that's not accurate. So what vaccines are we referring to? So for adults 18 and up, of course, we mentioned the flu shot every year. Tdap, which is tetanus, diphtheria, and pertussis, recommended every 10 years, starting at age about 21. As children, we get that last shot around 12 or so, 11 or 12. So then starting at 21, you would get the booster, and then 10 years after that. The reason that this is particularly important is because not only does it have the tetanus, which of course, prevents lockjaw, which I can thankfully say I've never seen in my 20 plus year career, but it also has pertussis, which is particularly important because that's the bacteria that causes whooping cough. And we've seen a surge in that, whereas whooping cough used to be kind of back in the 50s and 60s. We are seeing a bump in those numbers now because what's happening is that people who were kids then and got the vaccine, their immunity is wearing off. And now these people are grandparents and they may be caring for younger children who are not completely immunized. And so those babies and younger children can be susceptible to whooping cough. So that's why we really recommend it, because it's not so much mainly for you, but to protect if you have young children that you care for or exposed to. If you were born after 1957, you need to get your MMR, which is mumps, measles, and rubella. And these, of course, are general recommendations. You, of course, would have a personalized conversation with your doctor based on what your risk factors and allergies and sensitivities might be. But in general, this is what's recommended by the CDC and other national experts. Starting at age 50, you can get the shingles vaccine, which is to protect you against, if you've had chicken pox as a child, the shingles is that painful rash that you can get. So now there's a vaccine for that. Mid-adulthood, 27 to 45, and then this is kind of new because it used to just be for kids up until age 26, but now it's actually for up until the mid-40s, human papillomavirus, which is the virus that causes genital warts. And actually in women, there are some subtypes that can cause cervical cancer. So that's why we have a vaccine for that. 65 and up, there are a couple of different pneumonia vaccines that are recommended. You get one and then you may get another one a year later. If you got your pneumonia vaccine before age 65, because say you had asthma or lung problems or heart disease or other chronic issues that increases your risk for pneumonia, if you got it before age 65, then you would get another booster after age 65. Hepatitis A and B. Hepatitis A particularly is for people who have certain risk factors such as liver disease, if you have HIV, and for men who have sex with other men, certain other chronic conditions. If you have a job that may expose you to hepatitis A, where you're coming in contact with body fluids, travel to countries where it might be common, though that would be something to get. And then hepatitis B, similar risk factors, but B is definitely a sexually transmitted infection. B is sexually transmitted. So you would get that series as well. And then there's also meningitis vaccines and Haemophilus influenza type B. These are two bacteria that can cause meningitis. It can cause ear infections, throat infections, lung infections such as pneumonia. People who are going to be at risk for that are people who may not have a functioning spleen, who may have chronic kidney disease, who may have had certain transplants, so their immune system is suppressed. So again, this is something that you would discuss with your doctor, but I just want to show you the list of vaccines because people tend to think, oh, vaccines are just for babies, or, oh, I cut myself, let me go get my tetanus shot. But there's actually a lot more to it than that. And then hopefully this time next year, will we have a vaccine for COVID? That remains to be seen. So everything is not because you are getting old. And I can't tell you, when I was practicing, and I would have young people tell me this, like people in their 30s who were just so willing to chalk up a symptom to, oh, I'm getting old. I'm like, you're in your 30s. Like, wait, you're not old. And even, 50s, 60s, 70s, I mean, there are healthy, we tend in this country, we live with a lot of disease. We're one of the unhealthiest countries, in the world, considering what we pay in healthcare dollars. We're not getting a very good return on our investment as Americans. So we're seeing people living with chronic diseases, younger than what they typically should have. But at the same time, we are seeing healthy geriatric patients that are people who are in their 70s, 80s, and 90s and thriving. So I just want to just kind of spend some time talking about, don't just brush things off because I'm getting old, because it may be something much more serious going on. So for example, feeling short of breath, or you can't exercise like you used to. This can manifest in a variety of ways. If you can't lay down flat at night, you notice that you have to prop up with pillows. You may sit up on the side of the bed, kind of leaning forward just to catch your breath. Getting up several times a night to go pee, or just having not you can't go up a flight of stairs like you used to. Yes, that could be due because you're a smoker, but you also want to make sure it's not your heart. Those can be signs of a failing heart, particularly if you're swelling, you're having puffiness in your hands, face, feet, or legs. So don't just chalk it up to that. Go get that checked out because it could be something going on with your lungs or your heart. Similarly, if you're having chest pain, people think, oh, I'm just out of shape. I need to exercise. But if you notice that when you are, walking down the street, or minimal exertion, and you're getting chest pain or chest tightness, that needs to be looked at. Don't just think it might just be heartburn, or maybe I just pulled a muscle in my chest. Go get that checked out because particularly if you have diabetes, or even in women, they may not have typical heart attack symptoms. Like I can think of at least three female patients who I admitted who thought they were having heartburn and they were having a heart attack. So they may not get that crushing pain like the elephant sitting on their chest and going down the arm that you may have heard of. So you always just have to have that in the back of your mind. Headache. People say, oh, I'm just stressed out. I'm drinking too much coffee. I'm not getting enough sleep. It'll go away. Yes, those things are highly likely and possible, but a new headache in someone who's 50 or older, if you've never had headaches before, now if you've had migraines all your life and you're just getting migraines, that's one thing. But in general, even if you've had a lifelong history of migraines, the older you get, those typically get better, particularly women when they go through menopause, right? Because you're not having those fluctuations from your hormones. So if your headaches are changing in any way, if they're getting worse, or if they're new for you, you need to get that checked out. There can be, brain tumors. You can have excess fluid on the brain, blood on the brain, any manner of things. So don't just, chalk that up to it's just a headache, particularly if you're having, what we call neurologic symptoms. You're noticing changes in your vision or hearing or balance or numbness, anything like that. Get that checked out. Weight gain or weight loss. So yes, yeah, again, menopause is not just for women. So I don't know if we have any fellas join the call or the meeting, but men go through a type of menopause as well. And so basically that just means, our organs are not putting out the same amount of hormones that they used to when we were younger. Women stop having their periods. Men may notice that muscle is turning more to flab. They may have sexual dysfunction, erectile dysfunction. So you could certainly have weight gain because of that, because your metabolism is just slowing down in general. Um, or you may notice that you're losing weight. You're not trying to, but you're losing weight. Those definitely need to be checked out because your weight can definitely be affected by your thyroid. If your body is not making enough thyroid, you have you would have constipation. I'm sorry, you can have weight gain. And if your body makes too much thyroid hormone, it's kind of revving up your body, and you may have weight loss associated with also like diarrhea and sweating and fast heartbeat. But particularly, undesirable or an unexplained weight loss certainly needs to be checked out because could that be a cancer? Could that be HIV? Could it be some type of chronic infection or some type of disease, kidney problems, liver problem, anything that the body is not able to repair itself? You want to get that checked out. And then with weight gain, what type of weight gain is it? Is it really weight gain or is it fluid retention? Because like I mentioned earlier, when we were talking about difficulty breathing, if you're retaining fluid in your hands and your feet are puffy, then that can be a sign of either heart failure or kidney failure or liver problems. So, if you're noticing a significant change in your weight up or down, you need to get that evaluated. Joint problems, who I'll raise my hand, arthritis. My knees sometimes feel like I've been running I don't even know what. But, so arthritis, yes, who here doesn't know about arthritis? But all achy joints are not just wear and tear arthritis. There can be inflammatory types of arthritis. There can be infections in the joint. There can be gout. Even, sometimes cancer can present that way. So don't just chalk that up to being older. And then again, we mentioned the swollen legs as being a sign of potential organ failure. Changes in your bowel patterns, constipation or diarrhea. I'll tell you just a little bit. I mentioned earlier about my mom being a colon cancer survivor. Well, this is how she presented. She was living with me at the time, and I have my son then was probably about 6 or 7. And so one weekend, we all kind of had this stomach bug kind of thing. Just went through the house. Um, but then, 24, 48 hours, everyone, my son and I, symptoms completely went away. Hers got better, but about a week later, she was still saying, something just wasn't right. And up until then, she'd had no symptoms, at least none that she shared with me. And so, being the daughter doctor that I am, got her in to see one of the gastroenterologists who I actually had gone to college with, and he was now practicing in the area where we lived. And she ends up getting a CAT scan, and lo and behold, she had colon cancer. So if you're noticing a change in your bowel, particularly your bowel frequency, the size of your stools, because if you have a tumor that's big enough, it's going to affect the size of your stools. And that can cause constipation. You can even have diarrhea because depending on where the tumor is, if all that can get past it is liquid, you may have diarrhea because the solid stool just can't get past the blockage. So those are definitely things you want to look out for. So hopefully you're getting your colonoscopy starting at age 50 or sooner if there's a family history. So, so that we're not missing that. Obviously, blood in the stool would definitely warrant some attention. But I've even had patients, blow that off. Oh, I just have hemorrhoids. Unless a doctor has told you have hemorrhoids, don't just diagnose yourself with hemorrhoids. Now, if pregnant women, truck drivers, people who are constipated a lot, obese people, those are all risk factors for hemorrhoids. So in likelihood, could it just be that? Yes. But again, you can't see that area yourself. You don't want to just assume and then have it be something more that should have been caught or could have been caught earlier. Skin changes. We talked a little bit about skin cancer. Skin changes, as we get older, the skin gets less elastic, doesn't have the snapback like it used to. We get more wrinkles, some sunspots, things like that. But if you notice any change in any moles that you've had, some of us are pretty moldy. There's 5 things that we look for when we're talking about moles, and it's A, B, C, D, E. So A stands for asymmetry, meaning what does the mole look like? Is it perfectly round or does it have jagged edges? Or can you cut it in half and kind of fold it over on top of itself and it fit neatly, or does it look uneven? Is one side bigger than the other? B is borders. What do those borders or the edge of it look like? If they're nice and smooth, more likely to be benign or not worrisome. If they're irregular or jagged, that's more concerning. C stands for color. And mold should be the same color throughout the whole mole. If it's purple on one side and maybe red or brown and it's just got all these different funky colors in there, that's a mole that needs to be looked at. And D stands for diameter. So roughly, if it's bigger than the size of a pencil eraser, so that's about 6 millimeters, or about half a centimeter, you want to get that checked out. So a pencil eraser or smaller tend to be okay. And then the last letter E stands for elevation, meaning is it flat or is it raised? Flat things tend to be benign, whereas raised make us definitely more concerned about the risk for cancer. So if you're noticing any of those things, you definitely want to get that checked out. And then hearing and vision changes. Again, this is a very common one. People say, oh, I'm just getting older. I can't see as well. I can't hear as well. But there are common eye conditions, glaucoma, macular degeneration, cataracts. All of these affect the vision in certain ways. Cataracts can cause kind of a haziness over, like almost like a film over the eye. Glaucoma can affect the peripheral vision, whereas macular degeneration affects the central vision. So if you're trying to look at the page and you can't see the center of something, that could be macular degeneration. So please do not just chalk up vision changes to being old, particularly if you're diabetic. That can cause a whole, set of problems with your eyes as well. And then hearing can be anything from chunk of wax in there, to eardrum problems, to just there can be brain tumors that affect the hearing, may also affect your balance with that as well, ringing in the ears, any of that, especially if it's new. Do not just chalk that up to I'm just getting older and it'll be fine. Because some hearing loss can be normal, particularly if occupational hazard, if you worked around loud noise, vibration, things like that, or if you went to a lot of concerts as a child or a young person and didn't wear earplugs. But you just want to have your doctor check that out and make sure that that's what's going on. So that's pretty much all I have. That's the end of part one. We'll talk more about some other things in part two, but I wanted to leave time for questions and answers. As you guys know, I've written a book, and this is the Meal Masters, your simple guide to modern day meal planning. So I am going to stop sharing my screen and take some questions.